Hi everyone. Oh my gosh, that's loud. It's great to see everyone here today. My name is Michelle Leach. I am moderating the session today. I come from the traditional territories of the Kwalindun First Nation and the Ta'aquatcham Council, which is also known as Whitehorse, Yukon. And that's where I've lived for the last 10 years. We have a really great lineup of speakers. I'm happy to see you all here. Speakers have 15 minutes allotted, so there'll be 10 minutes of talking time and around 5 minutes for questions. And then I would encourage everyone after this session to head upstairs to the penthouse level where there will be poster presentations and some networking. So I will move on to our first speaker. Right now we have Dr. Ronald Eliosoff. You'd like to come up, thank you.
You can hear me okay? First, I'd like to thank the organizers of this conference for inviting me to give this presentation. I'm a primary care physician with a long-standing interest in medical management of obesity, and this slide pretty much sums up my presentation. I'd like to make clear at the outset I have no affiliation with any bariatric surgical program at the present time. The following is a series of obesity maps of the United States starting in 1985. In 2012, they changed the colors basically because they ran out of red, but the trend continues. This is an obesity map of Canada. We're now seeing similar explosions of obesity in just about every country in the world, including China and India. These are some of the medical conditions that are caused by or made worse by obesity. So what options do we have for treating obese patients? Weight loss programs called short-term weight loss that is invariably followed by long-term weight regain with all of the humiliation and depression and demoralization that comes with that weight regain. This is a presentation that I recently gave at Oxford University in which I reviewed medically supervised weight loss programs in much more detail. It was very well received, and I've posted it on YouTube for anyone who might be interested. So what other options do we have? I believe that the new incretin-based weight loss medications are the most important medications that have ever been developed. Not only do they treat obesity and diabetes, but they improve blood pressures, lipid profiles, liver disease, kidney disease, sleep apnea, and arthritis. And they've also been shown to prevent heart attacks and strokes. Semaglutide and tirzepatide are currently the most popularly prescribed ones, but many more are on the way. And that's all I'm going to say about weight loss medications in this presentation. Let's go on to bariatric surgery. Bariatric surgery refers to a number of operations that have been specifically developed to enable obese patients to lose weight. The sleeve gastrectomy is by far the most commonly performed bariatric surgical procedure in the world. It was developed by Dr. Michel Gagné, who is a Montreal-based bariatric surgeon. In fact, Canadian bariatric surgeons may have contributed more to this field than any other country in the world, including the United States. With the sleeve gastrectomy, the outer part of the stomach is lopped off, leaving a much narrower and smaller residual stomach. Intuitively, one would think that this operation would work by simply restricting the amount of food that can be consumed at any given meal. However, that is not its main mechanism of action. Ghrelin, peptide Y, GLP-1 are hunger hormones. By altering the levels of these hunger hormones, bariatric surgery dramatically reduces patients' hunger, and that's what enables them to lose weight. The Swedish obesity study was a prospective study in which 2010 bariatric surgical patients were carefully matched against 2,037 medically treated patients. After an average of 11 years, they found a 30.7% lower mortality rate in the surgical group. One of the major findings from this study was that the surgical patients had a much lower incidence of cancer. In fact, the reduction in cancer deaths was almost as great as all the other causes of death combined. This was a completely unexpected finding. This was a similar study out of Utah. After 7.1 years, there was a 40% lower mortality rate in the surgical group. They also were taken by surprise by a large reduction in the incidence of cancer. In this study from the Cleveland Clinic, matched 22,000 patients who had undergone bariatric surgery with 66,000 carefully matched patients who didn't. After only 3.5 years, they found a 33% reduction in the incidence of cancer. These findings have been replicated in many other studies. In fact, the reduction in cancers, particularly amongst women, may well prove to be the most important single health benefit of bariatric surgery. Just out of curiosity, how many people in this room knew that bariatric surgery was associated with a reduction in cancer? Very, very few people know that. In fact, very few doctors know that. If you ask your doctor, is it true that bariatric surgery and obesity is correlated with cancer, they'll almost always say no. Just go to ChatGPT and ask them. These are some of the obesity-associated cancers that can be prevented by bariatric surgery. The Canadian Cancer Society recently estimated that the total societal cost of treating cancer in Canada in 2024 was $37.7 million. Bariatric surgery also causes a rapid and dramatic improvements in diabetes. Diabetes Canada recently estimated that diabetes consumes $18 billion annually. And each of these other medical conditions are greatly improved or prevented by bariatric surgery. A recent editorial published by the Canadian Journal of Cardiology estimated that hypertension costs about $20 billion a year. A heart attack admission costs around $21,000 per admission. A knee replacement costs between $18,000 and $30,000. A stroke costs between $74,000 and $107,000 in the first year alone. Hemodialysis costs between $95,000 and $107,000 per year. A recent comprehensive Canadian health economic analysis projected that obesity costs $21.7 billion annually in indirect costs from absenteeism, disability payments, reduced productivity, and lost earnings from premature death. This meta-analysis compared the long-term outcomes of bariatric surgical patients with carefully matched medically treated patients. It included over 170,000 participants. Their conclusion was that bariatric surgery had extended the average lifespan of diabetic patients by 9.3 years and non-diabetic patients by 5.1 years. The sleeve gastrectomy that is performed today is radically different from the sleeve gastrectomy that was performed 20 years ago. The sizing and shaping of the residual stomach has changed, and we're using much more efficient staplers and other surgical equipment. As a result of new developments in technology and technique, bariatric surgery keeps getting better and better and safer every single year. A sleeve gastrectomy or a gastric bypass is now safer than a gallbladder removal or a hysterectomy. Many centers are now offering sleeve gastrectomies on an outpatient basis. Patients have their procedure in the morning, they are sent home in the evening. Some centers are even offering endoscopic bariatric surgical procedures. These operations simulate a sleeve gastrectomy, but the entire procedure is done with an endoscope that is inserted through the mouth. This requires no abdominal incisions at all. This is my former associate, Dr. Tom Lavin, describing the POSE procedure. These procedures are now being routinely offered at the Mayo Clinic, Johns Hopkins, and several Canadian centers. The cost of a sleeve gastrectomy or gastric bypass in Ontario currently ranges from $10,000 to $14,000. On November the 7th, 2022, the American Society of Metabolic and Bariatric Surgery, and IFSO, the two largest bariatric surgical organizations in the world, issued a joint statement in which they updated their guideline recommendations to bariatric surgery. These were based on an enormous body of high-quality research, including 13 randomized controlled trials. Bariatric surgery is now indicated for anyone with a BMI greater than or equal to 35, or for diabetics with a BMI as low as 30. Alex is a diabetic patient of mine who had a BMI of 35 before his gastric bypass. This is his picture after his surgery, and he is no longer a diabetic. This is a photograph of Dawn and Oscar before their gastric bypasses. Dawn had her gastric bypass first and lost 107 pounds. This picture was taken soon after Oscar's gastric bypass. He's lost a great deal more weight since then, and he recently completed his 3rd marathon. I actually saw him yesterday, and 2 days ago he completed half the marathon of the Ottawa run. This is a picture of Renee before and after her duodenal switch. The problem with bariatric surgery is that it doesn't just make you healthier, it also makes you look better. If bariatric surgery made people look ugly, we say that's just the price one must pay to be healthy. If you email me, I'll send you a 7-page PDF with hyperlinked references to support each of the claims that I've made in this representation. Thanks for listening.
That was fascinating. Are there any questions? Go ahead.
Do you think the new medications will eventually replace bariatric surgery as the primary approach that's taken?
You've asked a really important question. If you go to any endocrinology conference in the world, especially North America, that is exactly what they're saying. That these medicines are so good they're going to replace bariatric surgery. The data just doesn't support that. It's almost certainly not true. What is not appreciated is just how safe bariatric surgery has become. Very few people know, but very few endocrinologists know this. Safer than a gallbladder removal. Now, suppose that you had recurrent abdominal pain from gallstones, and if you avoided eating fat completely, so you avoided fried foods, you avoided oil, then you don't have any abdominal pain. And so you could get away with it. But if you go for a gallbladder operation, they'll remove your gallbladder in an outpatient procedure, and you won't have that problem anymore, and nobody hesitates. But if you go for bariatric surgery, you get this long litany of complications which rarely occur anymore. And the bariatric surgery is safer than the gallbladder operation. And gallbladder problems are associated with obesity, so you have that complication. So no, I don't think so. And I doubt even in the future that you're going to be able to. One single outpatient bariatric surgical procedure, you're home the next day, you're at work a week later, and then you don't have to worry about taking injections every day for the rest of your life.
We have time for another question. Is there another question? Go ahead, please.
First off, exceptionally well presented. I'm 140 pounds and I want a bariatric surgery, so well done. I think it just what captures me here. I'm a layman in the space, but I'm interested that there's all these avenues between the medications, the surgeries. Like, is there still any space for behavioral changes with diet, exercise, those sorts of things, or is that just indicated for a specific subset of?
Okay, with the diet and exercise, again, I have that presentation that you can look it up on.
Yeah.
Again, to Oxford, but basically the idea of diet and exercise obviously is the way to go. It just makes sense. There are several long-term studies that show that yes, you can enter any weight loss program, including all the ones sponsored by all the major universities in Canada, and you will lose weight. But the long-term studies clearly show that they regain all their lost weight. And the process of weight regain is very unpleasant, and nobody discusses that. The reason we have this, like why do we have this obesity epidemic? And the answer is fairly straightforward. Our ancestors didn't evolve to have McDonald's in every corner, eat up food, restaurants, cars, televisions. We just didn't evolve to live on our luxury cruise that we live on. And if you're biologically predisposed to obesity,